Continuing our discussion on innovations in CLL, we're going to now talk about relapsed refractory CLL and standards of care. We have Dr. Bita Fakhri from Stanford and Dr. Nitin Jain from MD Anderson, both respected figures in this field. So, Bita, let's shift to the relapsed refractory setting. First scenario, true disease progression on a continuous covalent BTK inhibitor. Where do you generally go? Do you test for BTKI resistance mutations?
Yeah, if it's a true progression, I certainly check for acquired BTK inhibitor resistance mutation panel. And now we are learning way more. C481S was a very common one, PLC gamma 2. And now with the newer generation covalent BTK inhibitors, you're learning about new mutations like T474 with acalabrutinib, L528 with zanubrutinib. It's validating to find one of these mutations when someone truly progresses on a covalent BTK inhibitor. But we also know that 40% of patients who progress have one of these mutations. So when you see true progression, I bring them back, twice, a few months apart. And if I'm convinced that they're progressing, and even if I do not find resistance mutation, it's time to switch therapy. So because of the similarity in mechanism of action, if someone has progressed on one covalent BTK inhibitor, all three of them, ibrutinib, acalabrutinib, zanubrutinib, are out. So I would not switch from a covalent. For example, if they're on acalabrutinib, I would not go to zanubrutinib because they all form a covalent bond with, the same site. So it's time to switch class. And now we know that with venetoclax-based therapy, the Morano trial resulted in the FDA approval of rituximab venetoclax. But I think we have learned from different trials, including, CLL13, which was obinutuzumab venetoclax versus rituximab venetoclax versus, triplet therapy, rituximab, obinutuzumab, ibrutinib venetoclax versus chemoimmunotherapy, that surprisingly, rituximab venetoclax is similar to chemoimmunotherapy as compared to obinutuzumab venetoclax. So extrapolating from that trial and also other trials, I think there is a universal understanding in the field that obinutuzumab is not just a me too in terms of CD20 monoclonal antibodies. It does result in deeper remission. So if I choose to go down the route of BCL2 inhibitor-based therapy, my CD20 monoclonal antibody partner is obinutuzumab, and now it's in NCCN guidelines. So hopefully all the practices will have an easy time getting the approval. And also in